First case, 55-year-old patient with history of increase in ALT and AST. The liver shows at least 30% macrovascular steatosis. In this area, we have focal increase in neutrophils, and the trichrome stain shows areas of pericellular fibrosis and ballooning. So your diagnosis is, this is a steatohepatitis. We know by history that it's alcoholic, but the diagnosis is NASH. The differential diagnosis is with NASH. Next case, excision of colonic polyp. Pretty remarkable here for these kind of areas. Some areas like this, the diagnosis is, we sign this case as adenomatous polyp with high-grade dysplasia. This is a 60-year-old patient with multiple abdominal lymphadenopathies. Endoscopic ultrasound of periportal adenopathy showed this diffuse lymphoid proliferation. CD20 positive, CD3 negative, CD5 negative, CD10 positive, BCL1 negative, MUM1 positive, CD23 negative, BCL2 nuclear positivity, very strong, CMYC nuclear positivity, significant, and then Ki67 at least 90% nuclear positivity. Diagnosis: we sign this case as high-grade B-cell lymphoma, consistent with diffuse large B-cell lymphoma with double hit. The double hit CMYC and BCL2 positive was confirmed with FISH. Next case, 2 centimeter subpleural nodule in the upper lower lobe, well circumscribed, obviously spindle cell sarcomatoid with mitosis. CD34 only positive in endothelial cells, CD56 membranous positivity, CD99 membranous positivity. This one is cytokeratin, completely negative. S100 consistently positive, nuclear and cytoplasmic. This one is Wilms, WT1 only membranous. Please note that the nuclear staining is negative, and this is SOX10 positive. So what's your diagnosis? We are very, very convinced that this is a metastatic melanoma, but something that we cannot entirely rule out with this immunohistochemistry is the differential diagnosis of malignant peripheral nerve sheath tumor. But we are in favor of metastatic melanoma. Next case, a 70-year-old man with 100,000 WBC count is increased. You can notice here a double peak with myelocytes, neutrophils, and these cells here, this one, and this one, basophils. Pretty hypercellular bone marrow with some abnormal precursors in abnormal localization, not peritrabecular. Also increase in eosinophils. Diagnosis: this is a case of CML, and it was confirmed with FISH for BCR ABL. And the last case that I'm going to present today is a patient with right pleural effusion, history of bronchopneumonia, aspiration bronchopneumonia, and cardiac failure. But I noticed these abnormal cells in the cell block. I ordered immunohistochemistry with MOC1, and BERF4 that was negative, and calretinin was positive in these clusters. So what's your diagnosis? Despite the atypia of these clusters and apparent community borders, the immunohistochemistry confirmed that these are not epithelial cells. So I signed this case as benign effusion with reactive mesothelial cells with MOG31 negative and calretinin positive.